Dr. T here. Welcome to Wednesday Q&A. How is everybody going? We are right in the middle of school holidays. I hope you guys are getting through. There's blessings in every day. I'm going to wait till a few more people jump on. I hope you've had an amazing day today. I have had a really great day. I've got this fly in my room, so it's probably going to run straight across in front of me. I'm probably doing this all night long, but I'll wait till there's a few more people come on. But I had the opportunity to really be present with my kids today. So if there is, if there is a blessing in my day, it is about the importance of being present and living in the present and just being in the moment. So if that's a little blessing for you, take that one on board today as well. So I have got so many amazing questions that have come through today. And so I'm just going to get going with these questions. And I'm hoping if these are questions that you have answered, they are going to be helpful for you. I want to remind everybody that the answers to the questions are very generic. So I try not to be specific in my answers. If you have further questions about your specific situation, then please don't hesitate to get along to your fertility specialist, to your endocrinologist, to your GP, so that they can help kind of guide your specific situation. This fly is going to annoy me. I'm going to try and get it out of this room. Hang on a sec. I'm not going to have success. This could just be a really interesting night, me trying to get this fly out of the room. Anyway, okay, I'm going to start with the first lot of questions. About half a dozen people asked questions around recurrent miscarriage. They were all different scenarios. So some was primary recurrent miscarriage, some was recurrent miscarriage after having a successful pregnancy. But I think what I'm going to do is just package it all up in just addressing recurrent miscarriage. So it depends which part of the world you actually come from as to how recurrent miscarriage is determined. If you're from North America, then it's 2 or more miscarriages in a row, consecutive. If you are from the UK, then it is 3 or more. But in fact, they've actually done studies to look at the difference between 2 or more and 3 or more, and really there is absolutely no difference in factors whether you have 2 or more recurrent miscarriages consecutively or if it's 3 or more. So hence why the Americans will tend to institute some investigations after 2 pregnancy losses in a row, which I kind of think is really reasonable. So when you're looking at recurrent miscarriage, so this is when you spontaneously fall pregnant or you fall pregnant with assisted reproduction and then the pregnancy is lost, generally within the first trimester. About 50% of the time, you never find a reason, which is really, really frustrating. Despite all the investigations that you do, you don't find a reason. And that's often really unsatisfactory for patients and often a little bit anxiety provoking, because then the discussion is around, well, why don't you just keep trying? And then there's that threat of the potential inevitable next miscarriage, which in most situations doesn't occur. So if 3 or more miscarriages in a row happens in around about 1% of the population. One miscarriage happens around about 20% of women will have had at least 1 miscarriage. So it's not an uncommon scenario, but when you get to 2 or even 3 miscarriages, it starts to get a little bit less likely to happen. So down to 1% with 3 or more miscarriages in a row. So 50% of the time, unexplained. Of that other 50%, about half of those is due to chromosomal copy number abnormalities in the actual fetus itself. What do I mean by that? Well, we all should have 46 chromosomes. We're either a female, 46XX, or where a male, 46XY, that is considered to be a normal karyotype or normal chromosome copy number. In miscarriages, about 50% of those where we know a reason, it happens because there's either too many chromosomes or not enough chromosomes. So trisomy, for example, where you've got 3 copies, of any one chromosome. Trisomy 21 is the one that we all talk about. That's Down syndrome. That's where there's too many, there's 3 of chromosome number 21. And that actually is consistent with life. You can have a child born with Down syndrome. Many of the others, though, where there's too many or not enough of any one of the chromosomes, are not consistent with life. And so they'll start as a pregnancy, they'll continue along for a short while, and then they'll stop. So you'll get non-progression and ultimately miscarriage. So the vast majority is due to that. What do we know to be the most common cause of that? Well, most of the time it's due to a woman being older. So it's actually a chromosome copy number in the eggs themselves. About 5 to 7% of people will have something called a translocation, where, or it's a long thing to describe, but they'll have an abnormal arrangement, an abnormal structural arrangement of the chromosomes in themselves. So they've got all their material, but when they pass it on to their offspring, it can become unbalanced and abnormal. So that's another way you can get abnormal chromosome copy number. What is the next big group? Anatomical. So problems with the uterus itself. Somebody actually asked the question about having a postpartum complication after a pregnancy. Well, you can develop scar tissue, Asherman syndrome. You can have abnormalities that develop as a result of that in the growth of the lining of the womb. You can have structural abnormalities, septum. You can have acquired abnormalities, a fibroid or a polyp. All of these things can lead to problems with recurrent pregnancy loss. So it's really important to get a good 3-dimensional ultrasound to have a look for these things. And if there is a risk that you've developed Asherman syndrome, to actually get something called a saline sonohystogram, where they actually kind of outline the inside of the uterine cavity to look to see if there's scar tissue, or have a direct look with a hysteroscopy. Another big group of abnormalities is endocrine. We're very thingy about thyroid function. It's important to look at prolactin. It's important to look at the endocrine. Some groups don't necessarily support this, but others do support looking at things like insulin resistance and sugar abnormalities. Another big group is blood clotting abnormalities, so something called antiphospholipid syndrome, which can manifest in recurrent miscarriage. So it's important to look for the factors associated with that. Again, some groups support exploring hereditary blood clotting disorders, thrombophilias, though that's not universal. Another big group to consider, though somewhat a little controversial, is the immunological things. So looking for people that might have autoimmune disorders, celiac, for example, or even the very controversial area of looking at natural killer cells. So it's really important. And then there's this big vague group, things like, exposure to plastics, hair dye, makeup, male factor, high DNA fragmentation in the sperm, and so on. So there's this whole big group of things that should be looked at. One of the things that I think is exceptionally important is, if you are in the process of having yet another miscarriage, I would always encourage an analysis of the products of conception. I think that's really important. And there is some emerging evidence that suggests that using the new forms of gene screening, microarray, chromosomal microarray, to actually look in more detail at the products of conception to see if it can elucidate evidence of a chromosomal abnormality, whereas a simple karyotype might not do this. And there's a suggestion that up to 90% of the time, if you look at those screening for those factors associated with recurrent miscarriage, plus doing a microarray of the products of conception, you can come up with a cause to miscarriage. So I'm hoping that might help to answer some of those questions about, well, why am I having miscarriages? All of those things should really be discussed with your fertility doctor. an attempt to find a reason, and then a more focused discussion when a reason is found. All right, what else can we talk about? I think we've done miscarriage to death a little bit there. Someone has asked about cervical intraepithelial neoplasia. So let's go back to the beginning, because this can be relevant if someone is seeking pregnancy and they need to know how often they need to be screened, and they're trying to sort of plan their pregnancies around this. So cervical cancer, the main cause of cervical cancer is something called HPV, human papillomavirus. It is, as per the name, a virus that has a predilection for the cells on the cervix. And the virus is sexually acquired, so you have to have sex in order to get HPV, otherwise known as the wart virus, so we don't actually get physical warts developing on the cervix. There are about 100 different types of human papillomavirus, but the two that we care about the most is HPV 16 and 18. They're kind of the most oncogenic. 93% of cervical cancer, HPV, is thought to be the main predetermining factor. So that's why we do cervical screening tests, because we are looking for evidence of persistent HPV. Now, being a virus, there is no antibiotic that I can give you. Your immune system just eventually, ideally, has to clear it. But some people's immune system, it just evades the immune system. It gets inside the cell and it hides from the immune system. So it just stays in there and then it replicates, and then it can cause cell damage. Now, it is that cell damage that causes atypia, and that can lead on to malignant change in those cells. And so what we're looking for when we do cervical screening is persistence of the HPV virus, but also atypical cells, and they're graded. So if you were to come to me with persistent HPV and abnormal cells, what I do is I use a colposcope to look at the cervix, so it's a microscope, and we put some special dyes on, and what those dyes do is show up areas of abnormal cells, and then we take a directed biopsy. So it goes from screening with a cervical screening test to now diagnostic with a colposcopy and biopsy. Now, if that biopsy is low grade, someone like myself would say, see you later, come back in a year and we'll repeat the screen, or go back to your GP and we'll repeat the screen. If it comes back as high grade, what we call HSIL, high grade, then a LETS procedure is done. This is called a large loop excision of the transformation zone. This is a surgical procedure. And when you scoop out that tissue is sent off for analysis. Now, sometimes it can come back as low grade. We call that SIN1, cervical intraepithelial neoplasia grade 1. If it comes back as high grade, it can be 2 or 3. They're all precancerous lesions. Now, if it's a SIN, so anyone who has a LETS needs to have some surveillance. So you'll have surveillance at about a year after your LETS procedure. You'll get a repeat cervical screen. It's called a co-test. And we're looking for HPV and we're looking for abnormal cells. And then you'll get it another year after that. And if all 4 tests, 1, 2, 3, 4, at a year and then at 2 years are negative, you go back to normal screening, which is 5 yearly. So hopefully that just clears up the screening around HPV. But it's really important, guys. We are well on track with the vaccination scheme that happens in our teenage girls and boys to vaccinate against the 9 most common HPV strains. We are well on track to eradicating cervical cancer if we can significantly reduce HPV. So definitely recommend that to our young girls in high school, and definitely make sure you are regularly getting your cervical screening. It is one of the most preventable cancers with the screening program. All right, enough about that. Let's talk about another question. Oh, this is a really great one. Is egg embryo quality or endometrial receptivity a bigger issue or challenge in someone who has endometriosis? Awesome question. I love that. Endometriosis is an awful disease. It really is. And the problem with endometriosis is that it can affect fertility in so many different ways. It can affect the egg quality due to the inflammation. It can affect, if there are big cysts on the ovaries, the ability to ovulate and produce eggs. It can affect tubal function, and so it can cause obstruction or abnormal transportation of eggs, and so therefore eggs and sperm don't meet. And it can cause problems with endometrial receptivity, or the ability of an embryo to actually implant. If I were to pick one or the other, egg embryo quality or endometrial receptivity and endometriosis, I think I would have to put my money on its biggest effect being at the endometrium. Because of this, we know that women who have endometriosis have abnormal progesterone receptors. Even if we treat their endometriosis, their progesterone receptors are abnormal. It's part of the disease process. So I believe wholeheartedly that endometrial receptivity is one of the biggest issues, which is why we use medications to try and suppress the endometriosis before we would put an embryo back, particularly in women who have quite severe disease. So I hope that answers that question. Someone has asked a question about coming off the pill, not having a return in their cycles. I have answered this one before, but here's a really quick synopsis of this. Often the reason why women have not, after coming off the pill, you ideally should have a return to cycle, ovulatory cycle, fairly promptly, within a month to a couple of months. If you don't have a return of cycle for 6 to 12 months after stopping the pill, there is something else amiss. There is something else wrong. It is not because of the pill. So I would always ask a patient, what was the reason that you went on the pill in the first place? Because often just asking that question reveals the reason. So they might have gone on the pill for polycystic ovarian syndrome and management of irregular cycles. It might be that they went on the pill for problems with acne. It might be that they went on the pill because they were an athlete and they never had a period in their teenage years. So it's hypothalamic suppression. So there's lots of different reasons why the period might come back. There might have also been an incident that has happened since being on the pill that has led to them not actually having a return of cycle. So I would always go and have a look for some other reason. I wouldn't just be waiting forever. Certainly not beyond 6 months. I would not be waiting for the cycle to just turn back on again. Go and see a healthcare professional. Okay. Embryo transfers, better done with or without ultrasound guidance. The evidence does suggest best done with ultrasound guidance with a full bladder to be able to get a good ultrasound picture. Somebody asked the question, if the egg doesn't fertilize or the embryo fails between days 1 and 3, is it an egg issue? And if it fails beyond day 4 to 6, is it a sperm issue? No. The embryonic genome kicks in at around about day 3, cleavage stays. We know that the embryo genome itself as its own entity kicks in at around about day 3. Up until that point, it's the egg that has all of the internal mechanisms to help that early embryo develop. Because the sperm, once it fertilizes the egg, all the other stuff that belongs to the sperm, the cytoplasm, the tail, everything else just gets kicked out of the egg, and all that remains is the DNA from the sperm. And so it's the other organelles within the egg itself which help the processing and the development and gives the early zygote its energy. So I don't think that you can be that prescriptive. I think that if you get failure after about cleavage stage, there's a problem with the embryo. I don't think that you can differentiate if that's egg or sperm. I would definitely look to something with the embryonic genome itself. All right, I was hoping you'd talk about hormones at some stage. I thought I talked about hormones all the time. What happens in a stimulation? What hormones are you looking to see a rise in? What happens with progesterone? Awesome question. I love this. This is just talking about what happens in controlled ovarian hyperstimulation. So controlled ovarian hyperstimulation is what we do when we are doing an IVF cycle or a stimulation for an egg freezing cycle, for example. And controlled ovarian hyperstimulation we use similar drugs to what our bodies produce. So we give you something called recombinant FSH, which is the same as FSH that your brain produces, but in much higher doses. So our aim is not just to recruit one follicle and one egg each month, but to recruit the whole cohort that is growing through in that month. Because you actually release from the little storage, you release more than just one, you release a group. One would normally take off and the others just die. So in controlled ovarian hyperstimulation, we're giving you that hormone, but in bigger doses. So it's kind of like putting jumper leads on your ovaries. Now, how do we measure the growth of these follicles, the recruitment of these follicles to a point where they will potentially ovulate? Well, we measure estradiol, which is the hormone that is produced from the follicles. And so the amount of estradiol produced reflects the amount of follicles that are growing. And a really nice, and this is just a round figure, but a really nice ballpark is there's about, when you get to peak growth, there's about 1,000, I think it's picomoles per litre of estradiol for every follicle that's grown. That's a really nice ballpark way of thinking about it. So you're watching the rise in estradiol and you're watching the growth in these follicles. At trigger or LH surge, which you can sometimes see happening as well, you get a flipping to these follicles then producing progesterone. So after your trigger, you should start to see a rise in progesterone. If you're seeing a rise in progesterone before the trigger, that's something called early luteinization. We don't like to see that in controlled ovarian hyperstimulation. Generally, it will mean you don't get a fresh transfer because the lining will be post-mature at the time of transfer. All right. How long should a couple continue to try and conceive if there is extreme irregularity anywhere beyond 48 days in a cycle? I would definitely recommend going and seeing someone now. If you have monitored your cycles such that it is so irregular that it goes beyond 48 days in a month, that is disordered ovulation. Now, does it necessarily mean that you need IVF? No, of course not. But it means that you have disordered ovulation. Number one, you're not going to know when you ovulate. But number two, something is causing disordered ovulation. It could be thyroid dysfunction. It could be polycystic ovarian syndrome. It could be abnormal prolactin levels. But you must go and see a doctor, someone who is a fertility specialist, to investigate what is going on and potentially treat it such that your cycles could normalize and you might spontaneously fall pregnant. So you don't need to wait the 12 months to prove infertility. If you have ovulatory disorder, go and get it sorted now. Okay, hopefully that helps a few people out there. Oh, someone's asked this question a few times and it's hard to answer. I'll say this. Can you improve the formation of granulosa cells around an egg? The simple answer to that is no. The presence or rather absence of cumulus and granulosa cells at an egg collection and around an egg when it is collected, because we don't collect the egg naked, we collect it surrounded by cumulus. So it's a cumulus oocyte complex is actually what we're collecting in an egg collection. If you do not see that, that is a marker for poor quality follicles and subsequently eggs. You see, there is this beautiful relationship between a follicle and an egg, and they're constantly talking to each other. So the egg helps to communicate with the follicle to grow granulosa cells, which are the supporting cells that produce all of the good hormones, and vice versa. And if someone is communicating that you're getting very low granulosa cells, or naked eggs is another term, that speaks to very immature or poor quality eggs. So all of the things that your fertility specialist has talked to you about trying to improve egg quality, unfortunately we don't have the magic pill, but there are various strategies that we can try, though nothing has been conclusively proven to work. But it is a marker of egg quality. So there's not really anything that I can tell you to improve the formation of granulosa cells. Oh, someone's asked about intralipid. I've been waiting for this question, honestly. Is it useful? Is it controversial? Is there any evidence? Well, I'll tell you this. Intralipid is definitely controversial. So intralipid is actually a sterile fat emulsion. So it's a fluid that is made up predominantly of soybean oil. And there is some egg lecithin in there as well to act as an emulsifier. And it was designed to be used for something called total parenteral nutrition. So for those people who are chronically malnourished due to various diseases, that's what it was designed for. Now, there's been the suggestion that intralipid infusions, so it's given IV, may help to modulate, I don't know if that's the right word, but help to manage uterine natural killer cell activity around the time of implantation and thus potentially improve implantation. So the first issue really is whether or not uterine natural killer cell abnormality at the time of implantation is actually a thing. That's the first debate. Then the second debate is whether intralipid actually works to help manage that. And there is no robust evidence. There is a little bit of animal evidence, maybe a little bit of poor quality human evidence to suggest intralipid might work, but there is no robust evidence to show that it conclusively works. Part of the reason is probably because it's such a small population of people that we're looking at. We're looking at people with recurrent miscarriage. There's that recurrent miscarriage question again. So so you would have to have tens of thousands of people examined having intralipid to see if it actually works. And there's no big studies that are being done. It's not without risk. There are people that have allergic reactions. We don't know what protocol, what concentration, how often it should be given, how long it should be given. Should it be given throughout pregnancy, before transfers, after transfers? No one really knows. And so because of it, it is not well accepted as a treatment, and it's not something that I advocate. But I know that it is used out there. Okay. Oh, I think I might have even reached the end. I want to finish off with this. It's kind of a statement, really. And I think this is it's such a great statement question that this person has asked. And look, if this resonates with you, give me some love. But even more, if you think that it resonates with someone that you know, please share this with them, because I think this is a challenge for all of us. So this person has suggested that communication about side effects and symptoms around fertility treatment that is provided by fertility clinics is often really brief. They've said that it might be their perception, but they felt that they have not been given enough information onto how you feel, and that they're constantly going to social media for answers to questions. And look, I've had this discussion with, and I know there's many of my patients on here, but I've had this discussion a lot with patients about how challenging it is to give just the right amount of patient information without total overwhelm. Do I think that we've got it right as an industry? I think we can do better. And I think that we are all constantly challenged by sharing of information and communication. We are all working towards what is best for our patients constantly. I can tell you it's a constant education in motion for many fertility providers, whether they are doctors, whether they're nurses, whether they're psychologists, whether they're administration, whether they're embryologists. We are all constantly working towards the perfect system. Do I think anyone's got it absolutely 100% right? No, I don't. So we're always seeking feedback for how you guys think that we can do this better. Sharing of information in healthcare in general is challenging, whether we're talking cancer, whether we're talking kids' health, whether we're talking, thank you for some love there, by the way, but the field of fertility and managing this incredible emotional roller coaster that we're all going through is particularly challenging. You guys are going through something that is the equivalent of cancer treatment, but you're expected to just go about your daily life. So this statement rather, or question, do you think enough information is provided to patients on what to truly expect? I sometimes wonder. I will often sit there with patients and tell them, this will be like riding a roller coaster with a blindfold on. This will be the hardest thing that you have done emotionally, socially, financially, spiritually, relationship, and all of that. It will be the hardest thing. But they'll still come back to me weeks later and say, I never realized it would be that hard. So I think we're all incredibly challenged by this. But know that we as an industry are working towards making it better. We're working towards utilizing social media. We're working towards utilizing apps, better communication, better languaging, more accessibility. We're also now dealing with a younger population who can access information so readily now. It's just about making sure that people are accessing the right information. You guys all know Google. You got to search got to separate the trash from the treasure. It's often really hard. Oh, bless you. Thank you. But you guys, that there is a lot of noise out there, and we're challenged by that as much as we are challenged to give the right information, the right amount of information, and in the right way. So thank you for your honesty and your vulnerability in that question. And look, I think this is something that we can all work towards improving together. So make sure that you feed back to your fertility centres. If you come up with ways that you think things can become better and be done better, then I certainly would welcome that. So thank you for joining tonight. I'm going to head off. I'm hoping that I answered as many questions as I can. Remember, if this stuff is really valuable to you, please don't hesitate to share it. It's going to be of value to somebody else. Have a beautiful rest of your week. I certainly am, rounding up the school holidays, counting down the days. But remember, every day's a blessing. See ya.